Yes, we were a little bit gobsmacked that our very, very low budget, humble study from the UK was selected for an ASH-breaking abstract. You know, that was really quite exciting. So as you know, ITP is a rare disease. It's autoimmune with both an increased consumption and reduced production of platelets. Not only can patients suffer from bruising and bleeding, but fatigue and impaired quality of life are also big issues. As you know, current recommended first-line treatment is with high-dose corticosteroids, and that's been the same for decades. But there are really big issues with this. So nearly all patients suffer side effects. One survey reported that 98% of people suffer at least one side effect, with 38% having to stop or reduce dose due to intolerable side effects. The other big problem is the heterogeneity of responses. So about 30% of patients fail to respond at all to corticosteroids at tolerable doses. And the majority of other patients relapse at some point in the future when the dose is reduced or stopped. So with this approach, only about 20% of adults remain in long-term remission. So this whole talk, by the way, is not pediatric hematology. So this is all related to adults. So the rationale for FLIGHT. So mycophenolate is commonly used as a second-line treatment for ITP in the UK. There are no randomized data, but there is retrospective data that suggests a decent efficacy with responses of about 50 to 80%, and that it's well tolerated if used in this context. One of the downsides of MMF is that responses can be delayed. So often if it's used for second line, you need either steroids or IVIG to sort of bridge the gap while it's getting started. MMF is generic drug, which is why there's never been a trial before, and it's cheaper than many of the other second-line options. So the FLIGHT trial aimed to test the hypothesis that combining MMF with corticosteroids is a more effective first-line ITP treatment than the current standard of care of corticosteroids alone. So FLIGHT was a multi-center, open-label, randomized controlled trial. Patients were eligible if they had a diagnosis of ITP, they were 16 years or over, they had a baseline platelet count less than 30, and a clinical requirement for first-line treatment. They were randomized 1-to-1 to either corticosteroid alone or corticosteroid combined with MMF. The corticosteroid could be either dexamethasone pulses or prednisolone, and the dosing algorithms in the protocol followed consensus recommendations. For the MMF, it started at 500 milligrams twice daily, going up to 1 gram twice daily if it was well tolerated. And at 6 months, there was a strategy to reduce and stop to avoid unnecessary long-term use. So the primary outcome was time from randomization to treatment failure, which was defined as a platelet count of less than 30 and a clinical need for second-line treatment. So that incorporates patients that were either refractory and didn't respond at all, or who initially responded and then relapsed. Secondary outcomes included side effects, bleeding events, and importantly, patient-reported outcome measures using validated questionnaires. So looking at the baseline demographics and baseline values, 120 ITP patients were recruited, and that was the sample size that we planned for. The mean follow-up was 18 months with a maximum of 24 months. The two groups are very, very similar in terms of age, sex, secondary ITP. The average starting platelet count was 7. So that sort of confirmed these were proper acute ITPs, not your kind of fatty liver disease people that have been hanging around for ages. So overall, about half were males, mean age of 54 years, with a range all the way up to 87 years. So if we look at the primary outcome, this is a survival free from treatment failure Kaplan-Meier plot. And in the blue, it shows the MMF, and in the red, it shows the corticosteroids patients. So there were significantly fewer treatment failures in patients who were randomized to MMF. So just 22% compared to 44%, with an adjusted hazard ratio of 0.41. And also responses were also better with patients who were allocated to receive MMF. So only 6.8% were refractory to the combination compared to 24.6%. And patients achieving a platelet count of more than 100 with first-line therapy alone, 91.5% with the addition of MMF compared to 63.9%. Of interest, the responses at 2 weeks were very similar, and this is a good reflection of the slower mechanism of action of MMF. So for the treatment side effects, there were very similar rates between the two groups. And importantly, the commonest side effects were really related to corticosteroids, with weight gain, difficulty sleeping, mood change being particularly common. Whereas if we look at the ones that you might be concerned about for MMF, infections were very similar between the two groups. There were no cases of neutropenia with MMF, and GI side effects were also very similar between the two groups. So there were very similar rates between the groups of bleeding events, rescue treatments, and hospital admissions. There were no intracranial hemorrhages or fatal bleeds, and no splenectomies. So the quality of life data is particularly interesting, and that's partly because if you look in the literature for ITP, really all the quality of life and fatigue data has come from chronic ITP patients. There's very limited data on newly diagnosed acute ITP patients. And the only drugs that have systematically looked at quality of life data are the TPO RAs, and all the other treatments that have been sort of tried haven't properly looked at quality of life. So this is quite a sort of novel added bonus to the trial. So we were really pleased that we managed to get nearly all patients to fill in these questionnaires for at least 3 time points. The fear of bleeding and the ICE-CAP quality of life results were very similar in both groups. Some aspects of quality of life seemed lower than the population norm at baseline. And some aspects of quality of life did appear worse in the MMF group. So that was the fatigue and also the SF36 physical. However, if you adjust your p-value threshold to correct for multiple testing, then actually none of them ended up being significant. So just a couple of slides on the laboratory sub-study, and this wasn't presented at ASH, but is also being written up at the moment. So those of you that helped us do this study will remember we took bloods at baseline and also at 2-month follow-up, and they were posted using good old Royal Mail, but special secure boxes, and they were processed by flow cytometry to look at T regulatory cells, B regs, and T cell activation markers. And the blood, we use something called transfix, which means that it's stabilized to enable sort of a bit of delay in processing. We've stored serum, plasma, DNA, RNA, and whole blood. And then with the EDTA blood, we did CD4 T cell isolation, cell culture, with or without dexamethasone, and T cell cytokine expression. So the aim of the laboratory sub-study is really to look at improving ITP diagnosis, but also prospectively validating a predictive biomarker of corticosteroid response that we previously assessed in a kind of heterogeneous chronic ITP cohort. So this is a busy slide, but essentially we did prospectively validate our CD4 T cell cytokine biomarker. So IL-10 to the IL-17 ratio seems to be higher in patients who clinically respond to corticosteroids. So this is quite a sort of useful additional output from the trial. So it's a very busy slide just to tell you that. I won't bog you down with the details. So this is quite interesting. So obviously, I'm sure you're aware that ITP is not an inflammatory disorder. It's a kind of more specific, antigen-specific autoimmune disorder. So if you do things like CRP, they're normal. So we were very interested to find out if there was any markers of autoimmunity or sort of immune activation that you could pick up that could help diagnosis. Because as you know, at the moment with ITP, it's a diagnosis of exclusion. And essentially, there were significant differences in T-cell activation markers compared to healthy control groups. These didn't help predict treatment response, but potentially, may be a sort of diagnostic utility. It obviously requires validation and comparison to other thrombocytopenic cohorts. So, this is the first randomized trial using dear old MMF, that cheap and cheerful drug, and actually shows good efficacy and tolerability, even though we inadvertently collected quite a lot of old people. So 27.5% were over 70 years and 15.8% over 75 years. The addition of MMF approximately halves the risk of refractory or relapsed ITP. And therefore, MMF may be considered first line alongside a short course of steroids for some patients. And interestingly, at final follow-up, actually the corticosteroid group did better than previous reports, and over half of those patients hadn't required second-line treatment. So it's unclear why some aspects of quality of life were worse in the MMF group, and there are many potential reasons for this. But it's a really important reminder that us doctors, when we're thinking about disease responses, actually it's not necessarily the case that the patient experience correlates with that. And it really emphasizes the importance of including these kind of outcome measures within trials. So the CD4 T-cell cytokine expression may help to define patients who would benefit most from early MMF by predicting patients who'd be refractory from corticosteroids alone. And it's possible that altered T-cell activation markers may help ITP diagnosis. We found that B regulatory cells were decreased in ITP following treatment, particularly with corticosteroids, with or without MMF. And huge thank for the HaemSTARs, partly because you have the kind of energy and enthusiasm. So a lot of you kind of helped nudge your PIs, and really, really grateful for the input. And I'm pleased to say I've submitted it to the New England Journal of Medicine, thinking it was a bit of a long punt, and they've sent me an early email saying that they're very, very interested. So it's gone to their statistician, it's gone out to external review and sort of gone through that phase. So that's, again, a bit of a surprise, this humble little cheap study. I will stop sharing. I don't know how long over time I've gone or under time.
Probably good that you don't know, that's fine. No, it's going okay. Does anyone have any questions for Charlotte about flight? If not, I have one question, which is maybe, I don't know if you can answer, but I presume I'm not the only one who doesn't know what's included in the SF36 score looking at patient-related outcomes. And is there anything in particular that we think led to the low reported outcomes in those patients on MMF?
So we have lots of theories. Okay, so one of them is that patients were actually taking treatment longer if they were assigned to MMF. So for, at least 6 months, whereas those who kind of got away with just one course of steroids were off drugs quicker. And there's quite a sort of psychological impact of taking drugs every day. I think as well, it's possible that MMF itself just makes people feel a bit tired. It may not be giving you infections or giving you obvious side effects, but it could be just making people feel a bit flat. I think the other theory is that patients who failed corticosteroid in the other arm may have got early TPO-RA, and potentially that has been shown to improve quality of life. So the honest answer is we don't know. I think the other thing is that this was quite an elderly cohort, and it's possible that if MMF is targeted to specific subgroups, and particularly if we look at people who are expected to fail corticosteroid, or in whom bleeding or relapse would be, really detrimental, then actually, that it may improve things more. So I was asked at ASH, should we be using MMF first line for all? And the honest answer is no, because if you're one of those people that gets on fine with steroids alone, then that would be, a good option. The key is to try and find a way to individualize treatment in the future, which is why the sort of combination of research activities that we're doing makes sense.